Okay, so this was back in December. 80-year-old lady presenting with altered mental status to an outside hospital. And, they got a battery of tests and they discovered, this was the first CT. They discovered on this CT that indeed she had some pleural effusion, some action in the lungs, but the key area of interest in her liver was this mild intrahepatic bile duct dilation. And then they reported debris in the central, in the common hepatic duct right here. I don't know if you can see this, but they said debris in the common hepatic duct, and she was thought to have some sort of cholangitis giving rise to altered mental status. And I'm going to show you her arterial phase as well. For some reason, they did get multiphase, which is great for us. So this is what her arterial phase liver looked like. If any findings of cholangitis, they're subtle. There are some areas that show hyperenhancement on the arterial phase, but I'm going to slowly go through this portion.
Does she have white count elevated? Was she obstructive?
She was mildly obstructive. T-bili was normal, but alk phos was in the 3 digits, not more than that, like 161 or something like that. And this is the picture we have. So they settled her, I'll show you multiple other images subsequently. They settled her acute condition, gave her antibiotics, she came out of that. And sure enough, because of this biliary finding, they got an MRCP. But before moving on to the MRCP, let me quickly show you. Sorry, I'm navigating this box for the first time, so bear with me.
You're doing an awesome job.
Okay, thank you. These are the coronal reconstructions from the portal venous phase. As you can see, there is some mild intrahepatic bile duct dilation, and then there is this gray opacity in the right hepatic duct going into the common hepatic duct here. She's had cholecystectomy previous. Scroll through the other way. I suddenly lose the right hepatic duct and then some portion of the common hepatic duct here.
There's like some soft tissue thing though in the duct, right?
Yes, indeed. Absolutely.
On the CT?
Yes, on CT as well, indeed. And then this is what her MRCP looks like. So there is this complete segment of duct that is missing. So the next step when she was stabilized is they went in, they did an ERCP, they stented her, they had brushings. The brushings came back negative for malignancy, but they also did a core biopsy. And I'm going to show you the core biopsy results later, only because they were not 100% sure whether the pathology that the core biopsy showed is actually what it is. She then was transferred to BI, and then a couple months later, 2 or 3 months later, we did repeat imaging. Imaging continued to show, let me show you. She was stented, but the imaging was not very different from what we saw initially. So I'm just going to show you the initial images. Now, if we go back and look carefully at the pre-stented imaging, that was her initial one, scrolling through, like you rightly said, I think that was you, Nelly, correct? For the soft tissue thing?
Yeah, it looks like an intrahepatic papillary lesion.
True. So if you look carefully at the arterial phase, here are the bile ducts. Let me window it. I don't know if you can see this. So if you can see, there is this focal arterial hyperenhancing rounded lesion, and then that seems to extend into the bile ducts. You can see that finding better on the portal venous phase here. So that is the duct. There's soft tissue within the duct. On the portal venous phase, it slightly washes out. I'm giving you the right clues. And then
is this like
there is a component
HCC invading the bile duct?
Indeed. And then there is a component in the parenchyma that also washes out. There is no capsule, so to speak. So indeed, the biopsy report from PATH came back as intrahepatic, or rather HCC. Now, I want to show you.
Did she have hepatitis or any like risk factors for HCC?
So she didn't, and her liver also doesn't, well, you might argue there is some widening of the porta hepatis, but otherwise no advanced features of cirrhosis or chronic liver disease. Spleen is okay, no ascites, portal vein was fine. But the reason they didn't believe the initial biopsy, because that came back as moderately differentiated HCC. And then Just to complete the picture, I forgot to show you the diffusion. So on the diffusion, there was this restricted diffusion within a small lesion, or rather small area in the parenchyma adjacent to the ducts, and then within the duct itself. Now, because they were debating whether this was purely an HCC or a combined or cholangio, we did a percutaneous biopsy of the parenchymal component as well. And actually, both were matching, both came back as moderately differentiated HCC. So I want to show you a few things on some literature search that I did. And last year, I also showed similar case, but that was purely intraductal, and that was mistaken for cholangio, operated, came back as HCC. Now, in this lady, serum CEA, AFP, CA99, everything was normal. So let me, hold on. So the top one is the path report from her ERCP, which came back as scant fragments suspicious for HCC well differentiated. And the bottom one is the percutaneous biopsy of the parenchymal component. Again, matches, came back as moderately differentiated HCC. And so every time I see something like this, to date, I've never been prospectively able to diagnose an intraductal HCC. Maybe with Victoria around, I'm going to get better at it. But the three questions that I always ask myself: if HCC is a tumor of hepatocytes, why should the epicenter be primarily in the bile ducts? So I looked at literature. The hypothesis, well, there are different theories, but one of the things is maybe this is not purely an HCC. Maybe once we operate and the whole thing comes out, it's more likely to be a combined HCC cholangiocarcinoma. And then, in the literature so far, they say about 0.53 to 9% of HCCs grow into bile ducts. As we all know, HCC grows more commonly into portal veins, less commonly into hepatic veins, and least common into the bile ducts. So there are some papers out there. There is one paper which states that once there is so-called tumor thrombus into the bile ducts from HCC, this is a poorer prognosis. And they've noticed that these HCCs are usually infiltrative, and they tend to recur. They have a higher incidence of recurrence. And these have better prognosis following surgical resection than without. And then there's another paper which says when HCC grows into bile ducts, first order involvement of bile ducts has an independent prognostic factor, irrespective of surgical management. Interestingly, they all call HCC growing into bile ducts as tumor thrombi. And then this question remains, and again, open to the audience: how can I prospectively raise suspicion for intraductal, also called icteric or cholestatic HCC? So, I
feel like the word tumor thrombi is so misleading.
I know, I don't. But interestingly, that's why I put it in parentheses. They call it tumor thrombus.
I think like tumor in vein, we should call it like tumor in duct or something.
Yes, I agree. That's more descriptive.
So there's really no good way to call this prospectively. There's no way to call this. The only way is if you have a parenchymal mass that meets criteria for HCC, and then that clearly invades the bile ducts. Again, if you see something like this, probably the category should be LRM rather than LR5, because again, the probability of combined tumor increases. So that
Yeah, I mean, absolutely. I just thought it was interesting. There were two papers. The first one from 2010, European Journal of Radiology, says so-called bile duct invasion by HCC is commonly seen with poorly differentiated and infiltrative type of HCC without a capsule, so to speak. And then they all say how the hepatic component is small. In this study, they had a very small cohort, 21 patients. And then there is this more recent article, BMC Cancer 2020. And one point that they raised, and I don't know, moving forward, I'm going to keep an eye out. What they say is on the portal venous phase, with cholangiocarcinomas, the wall of the bile duct appears thickened and enhances the wall. Whereas with HCC going into bile ducts, the mass itself shows sort of washout or can show washout, but the wall of the bile duct doesn't enhance on the portal venous and delayed phase. So I thought that point that they used to distinguish HCC going into bile ducts versus cholangiocarcinoma was interesting. They had a larger cohort. They had 58 patients with path-proven HCC going into bile ducts. So I don't know this, if there are enough number of cases, maybe this may be a nice point for research or something like that. And then, as Victoria rightly said, if there is a parenchymal component, both show similar enhancement pattern, AFI and washout. Yeah, so that's all I have for today. I'll stop sharing.
Anu, great case, and I agree with Victoria. I think it's going to be so rare and so hard to differentiate between those two that it's mostly going to be, and also maybe it's not changing the management, because if these are such poorly differentiated HCCs, they're kind of on the cholangio spectrum, like they wouldn't be getting a transplant anyway. So it might not change the ultimate treatment, like you wouldn't treat it like a well-differentiated HCC kind of thing.
True. Yeah.
Okay, thank you. Ben said he has 3. You want to go, Ben?
Yes, hi, good morning, everybody. I have some cases. 2 of them are quick show and tell cases, and one of them requires a little bit of time to adequately go through the case. So I'm going to go ahead and advance share my screen so that we can get started. So I invite you to focus on the vessels here. This is a female in her 70s. Ignore everything else and just look at the vessels. Now, this is a little bit difficult on this sequence, but I can show the arterial sequences and I can show the arterial map, and that makes it a lot more straightforward. Do you guys want to venture a guess, or do you want me to move to the next sequence? Okay, we're gonna move. So this is the arterial sequence. And then just to make it a little bit easier for everybody, I'm going to share this image.
Looks like Leriche.
That is correct. This is Leriche, exactly. The other interesting thing about this case, this was a lady in her 70s. She came to us recently. This is the only imaging that we have for her. But they had known about this about 20 years ago. They placed a left-sided iliac stent, and there was collateralization to the contralateral right side. So the right lower extremity is getting arterial supply through the collateral vessels. The other thing for me to briefly point out is on the MRI sequences, we were looking at the kidneys, and on the nephrogenic phase, the left kidney is very nicely opacified, and the right kidney is not really getting too much arterial supply. So we raised the question that there may be collateral arterial supply to the right kidney. So that was one case. Just to go, in the interest of time, to go to the next case. This was a very nice case. Let me just make sure that the basically kind of trying to figure out what's going on. So I'm gonna scroll through this, and you guys can tell me if you want to look at a specific sequence or if you want any additional information. The outside read was pelvic mass. but I think we can definitely do better. And I wanted to share this case with the group and see what you guys think about it.
Ben, my friend just showed me a case like this, and hers though was more in the prostate, and it was a giant cystadenoma of the prostate.
That Aarti, actually, that's we went back and forth with this, but we also think that this is coming out from the prostate, and that's what we ended up saying. We said cystadenoma versus cystadenocarcinoma, and this case is a recent case. I don't have any biopsy or additional information after our read was placed, but this was an interesting case. I hadn't really seen this before, and that's just an entity for me to be aware of, and I wanted to share with the group. This final case requires a significant amount of discussion because it's a case that keeps on giving. So I'm just going to open it up. We'll go through it, and then you guys will tell me what you would like. So I'm going to start with the CT that was done for this patient. If I can get this to become bigger, that would help me. Okay. So there's a patient that came in, and they were having abdominal pain. And when the ED did their labs, they found this person to be anemic. This CT was subsequently done. And I'm just scrolling through the relevant areas. And there's a finding. There's two findings that you guys have seen, but there's a finding on this image that that explains what's going on. And I'm sure you guys are all aware what this entity is.
Yeah, so KJ in the chat is saying TS, so tuberous sclerosis, and also with a bleed.
Yes, that is what this is. But I wanted to after this patient was stabilized, an MRI was done, and there are a number of things that I wanted to discuss with the group. Aside from the AMLs bilaterally, two of which had previously been embolized, there are a number of other lesions, including this lesion in the spleen, which may be a lymphangioma. We can see the AMLs in the kidney. Incidentally, when we're looking at these patients, we're looking for neuroendocrine tumors in the pancreas, and we're looking for RCC and oncocytomas and other concerning lesions in the kidneys. But the AMLs, as they get larger and larger, have a higher and higher risk of bleeding. And as we can see with this patient, often these are significant enough that they require intravascular intervention to stop the bleeding. The other lesions for this patient were I can show. So there's 3 different lesions in the liver, all of which were different from each other. There was, let me just push this over from here. I'm just going to stop share for 1 second so that I can bring over 2 additional sequences, and then I'll reshare the screen. In the liver, which has Indian artifact, which would be consistent with an AML or a fat-containing lesion. There were these 2 other lesions in the liver, which one of them is here, and you can see on the T1 pre it was hypointense. And the final lesion was in hepatic segment 2 here. And we can see that it's a stealth lesion, which we think may be FNH. It wasn't seen on the additional available sequences. The only other thing for me to share about this case is that these patients get LAM in the chest and cortical tubers and subependymal findings in their CNS. This patient did not have any imaging of their brain, but that's something else to be aware of. So these three were my cases.
Awesome, Ben, thank you. It was jumping around for me. Was it jumping around for you guys? The presentation, or I don't know if it's just my internet speed, but okay. I'm going to share my screen. Does anyone else have cases?
I have a couple, but I can go after.
Okay. Okay, this is my first case. Please write into the chat or speak up. And the lesion is here on the rectum. And they saw a mass on colonoscopy. I'm not going to tell you what kind of mass they saw, like the description of it, but what do you guys think about this on just the T2 Sag?
How old is this?
Yeah,
patient?
Endometriosis.
Yeah, good. So it was like a 40-year-old female, and this we thought this looked good for like the mushroom cap sign, which I think Nelly had shown us before too. So we were, and you guys at the Mayo, we were, I think Teresa and Regina were telling us about the resection of these lesions. So we were pretty convinced that this was endometriosis with a mushroom cap sign. And what I learned from Regina is that if it's involving less than 50% of the circumference of the rectum, then the GYN surgeons can do a discoid resection and just remove it and then seal it up. But if it's like more circumferential, they need to start involving colorectal surgeons. Okay, so I'm going to show you a couple more. It was not endometriosis, but even here.
What, really?
Yeah. No, I know. This is like a totally. You think I'm just going to show you?
Of course, Aarti would never show something as simple as that.
I know, right? Seriously.
So one of the clues is that this is the T1 pre, and we don't see any.
No hemorrhage.
We don't see any T1 hyperintense foci.
But you don't have to see T1 hyperintense foci.
I know,
or DIE, right?
I know.
Doesn't.
I mean, I still, in retrospect, we call this like this is endometriosis, right? Anyway, turns out this was a leiomyoma.
What?
I was going to ask you, the
No.
uterus is absent and it's very dark on T2. I'm not even making this up.
What did you say? You had one that
I was going to
like
ask you, yeah, her uterus is absent and then this is very homogeneously dark on T2.
Yeah.
So endometriosis has differentials. I was going to ask you, is this a fibroid? Yeah.
Yeah. So, I mean, this is the other thing we don't know about this case is we were wondering, is this like, we don't know why she has her uterus out, but is this a fibroid that dropped onto the rectum, or is it like a GI leiomyoma? And you can't really tell. This was just biopsied like with FNA, and so you can't really tell on FNA. But I do have a couple of points. So one of them is that leiomyomas can be anywhere along the GI tract. They're more common esophageal, whereas GIST tumors are more common in other parts of the GI tract. So if you have a submucosal mass in the esophagus, you'll lean towards leiomyoma. If they're large, they can ulcerate and cause GI bleeding. They tend to be very T2 dark like this one, and they tend to be endoluminally growing rather than exophytic like GIST tumors. And I thought this was a really interesting point. Sorry, where's my thing? So these are the layers of the wall of the bowel. And you see there's several smooth muscle layers. You've got your oblique muscle, your circular muscle, and your longitudinal muscle. So you have several muscles of smooth muscle. And generally leiomyomas can arise from this circular layer of muscle. And that's why they kind of grow endoluminally. Whereas the interstitial cells of Cajal that give rise to the GIST tumors are at this like deeper border. And so they have more of a tendency to grow exophytically. So I thought that was interesting that like the ICC cells are kind of deeper, and that's why they kind of have more of a exophytic predilection. But I think for this case, a lot of us would say endometriosis, and I think that's reasonable. Okay, this is the next case. What do you guys think about the retroperitoneum here?
Fibrosis?
What, like you just call it fibrosis, like retroperitoneal fibrosis?
You might include lymphoma in the differential though.
Yeah, so this was like, we thought this was probably retroperitoneal fibrosis, and Anu is saying, or IgG4, exactly. And so lymphoma, we think about that also with periaortic soft tissue, but it usually lifts the aorta, it pushes the ureters aside, it might not obstruct the ureters. So we also have like obstruction with stents in place. And so this is more on the spectrum of retroperitoneal fibrosis. If you need to, you can biopsy this. So you can go retroperitoneally. The stents really help you because you can see where the ureter is and you can get a piece of tissue here. It's still kind of hard to make the diagnosis of IgG4 related retroperitoneal fibrosis. But anyway, the interesting part of this story is that they did biopsies of this and it was kind of inconclusive. They ended up doing surgical biopsy, and this turned out to be a desmoid tumor. So in our group, we were discussing, like people were saying like, oh, I didn't know desmoid tumors could look like retroperitoneal fibrosis. I didn't know if they could be so infiltrative. So I just wanted to show this as an example of that. Another interesting thing about this patient is they came back for an MRI, and we can see the retroperitoneal fibrosis here, but they were also having pelvic pain. And this is their ovary. This is the uterus. So you can see the ovary looks enlarged. There was some enhancement around these follicles. And then this is what it looked like on T2. What do you guys think?
It's like a torsion.
Yes, good, excellent. So this was actually a big, huge edematous ovary with that was torsed. And then do you guys know what this sign is called? Or what it means? Cookie just showed this, I think,
Follicles.
SAR.
Hemorrhagic on the perifollicular, although you'd like it a little bit more T2 dark.
Oh, it's Cookie. Every time I see this, I think of you. I feel like you've taught me this multiple times. So yeah, this is the perifollicular hemorrhage sign, which I think is a sign of non-viability of the ovary. Is that correct, Cookie?
Yeah, but although the entire, if that's the whole ovary, then it's got T2 hyperintensity, which is what you see with viable. So I don't know if that's the nidus of the corpus luteum as the source. What's the source of the torsion?
They actually treated this conservatively. They never resected it. The patient had all these, this retroperitoneal fibrosis and stuff. And so she and her pain resolved. So this was never removed. But I thought this was a good example of this hemorrhagic follicular sign. So you're saying it has mixed signs. So the edema suggests that it's still viable, but this perifollicular.
I'm not sure that's a follicle. That might be just the
regular corpus luteum.
Yeah, it's got some dark, I don't know, it's not really black.
Okay, that's a good point. These were all enhancing. You can have multiple corpus luteum? I guess that's possible.
No.
Because both of these were enhancing.
I mean, you should only have one, follicle, but that, it looks like a follicle. It does look like a follicle, but it's enhancing and it's not T2 black. So I wouldn't have called that the perifollicular hemorrhage, to be honest.
Okay. Great. That's awesome. I'm glad you were here. This, do you find like this T1 hyperintense rim was more suggestive of hemorrhage or no? Not really. No.
Show me back to T1.
This was here. T1 is here.
Yeah, that is. It's a little bright, but it's still iso-intense to like the bladder wall, so I don't know if that's really hyper intense.
Okay. Cool. So this might be a viable tumor, ovary.
Yeah, I would probably call that MOE at this point, massive ovarian edema, you know, and especially if she's
Yeah.
still hanging out, doing okay with it.
Yeah. Cool. Okay. And then just a couple of points. I have a couple of companion cases for the retroperitoneal fibrosis. This patient had a total colectomy. They have FAP and Gardner syndrome. And you can see that they also have ureteral stents and hydronephrosis. And they have this infiltrative soft tissue down here that in this case was actually extending anteriorly. And so this is also infiltrative desmoid type fibromatosis in this patient with Gardner syndrome. And then I have one more case of it. So this case, the patient also has FAP type Gardner syndrome, and they had these soft tissue masses. They were more rounded. They were less infiltrative than the other two cases I showed you, but multiple of them in the mesentery. And then this was 6 months later. So you can see that they markedly are growing really rapidly. And they were put on a number of medications. And then this was 6 months after that. So this was a very aggressive type of fibromatosis, desmoid fibromatosis in Gardner syndrome. And so desmoids can be very variable. They can be kind of quiescent over a long time, or they can be very aggressive, grow very rapidly. And this was the case of that. So I do have a couple of points about these two entities. So there is retroperitoneal fibrosis. This is an immune type of disorder. They see rheumatologists. There's a number of causes, but an increasingly recognized cause is IgG4 disease. These are more common in males, which is a little bit unusual for autoimmune disorders. And they can also be caused by radiation, NSAIDs, and be idiopathic. On pathology, you'll see dense fibrous tissue and a lot of inflammatory cells. If they have a certain number of IgG4 cells, that's when they start bringing up IgG4, and you can test the serum IgG4. And they're going to treat these by immunomodulation, like with steroids. Desmoid type fibromatosis is a type of deep fibromatosis, as opposed to like the more superficial ones like Peyronie's disease or plantar fibromatosis. These are much more common in patients with FAP and Gardner's, female patients with a history of trauma, because it's kind of like a keloid, and oral contraceptives. And pathologically, these are different. They're myofibroblasts with collagen, and they will stain for beta-catenin. And they're treated differently as well. So you might do surgery if it's kind of aggressive, although sometimes they'll just conservatively manage these because they tend to recur, because they can be infiltrative, and the edges often have positive margins. And you can treat these with NSAIDs, tamoxifen, and radiation. And there's a couple of newer agents that they're using with more aggressive cases. So even though they both can be retroperitoneal and they both have fibrosis in the name, these are different entities. In the first case I showed you, they actually discharged her from room workup because they said, oh, she's got a desmoid, and that's not a rheumatologic disorder. That's like more of on the mass, like sarcoma spectrum, and they're going to be treated with different therapies.
Aarti, I'm surprised the first case you showed us didn't look more mass-like and pushing type of. I always think of desmoids as kind of like a
yeah. I mean, that's actually why I wanted to show this case, because that was even though the path, like they biopsied it multiple times and then they changed the treatment, because initially we thought, oh, it's just retroperitoneal fibrosis, we're going to give steroids, but then now they know that this was actually desmoid fibromatosis.
That's unusual.
How are they knowing it's desmoid? I mean, there's really no molecular things that they look for desmoid on. I mean, it's still a fibrotic. I mean, how are they seeing that's desmoid now?
Well, this is what the pathologist told me, and this is why I wrote the stuff here, is that when in desmoids, they have these myofibroblasts, collagen, and this beta-catenin is actually a really big,
yeah, but not all of the desmoids have beta-catenin, right? We see lots of post-FAP that don't have beta-catenin. Many of them are treated with imatinib too. So some of them have different types of molecules for that, but I don't know.
Yeah. And so this particular case, they did stain for beta-catenin, and they did multiple biopsies and came to this conclusion. And they did say that pathologically, these two entities look different. So I do think that they can sometimes pathologically diagnose a desmoid.
It's
But I'm
just
not a
weird that
pathologist.
it's going along the entire course of the vessels all the way down. You know, it's just not the behavior of a desmoid.
Yeah. Yeah. I don't know. It was like biopsied multiple times and they discussed it extensively. So, okay, here is another case. This focus on the aorta. So we were looking at this aorta. And then it started looking like this. And I can show you the coronal.
Looks like it might be something enhancing rather than just a thrombus.
Yep. So, and then this patient has ECMO, and that's one of the clues. They're on ECMO. You can see this large ECMO catheter here.
Oh, like a mixing or something?
Yeah, exactly. So, hold on one second.
ECMOs play with your mind.
What'd you say? ECMOs play with your mind?
Yeah, the vascular stuff that you see in this is really confusing.
Yeah, so that's why I thought this was a really interesting case. So basically, this patient is on AV ECMO, so arteriovenous ECMO, which is different than VV ECMO. So when they do venous ECMO, they basically, that's usually for patients who have pulmonary disease, like, and sometimes very severe COVID. But when you have heart disease, they'll do AV ECMO more commonly. And so you can see here that they have this large ECMO catheter in their IVC, but they also have a femoral arterial catheter. So what's happening here is basically the deoxygenated blood is removed from this venous ECMO catheter, oxygenated in a machine, and then put back in through this femoral arterial line. And then this blood kind of goes, it kind of is jetted into the aorta. And so it's mixing with the contrast enhanced blood is mixing with the now newly oxygenated blood that's coming up the aorta. So this is kind of a known artifact that you can get if you're on ECMO when you get weird mixing of blood, because you're basically mixing like blood that's pumped out of the heart and blood that's being pumped back into the body. So I thought that was really cool because we were like, did they just thrombose off their aorta? Like, what's going on here? But this is actually an artifact from ECMO.
Sneaky.
And what'd you say?
Tricky.
Yeah, yeah. It took me like the longest time. My colleague Amir taught me about this, and he had to explain it like 3 times before I understood what he was saying. So
I never understand it. Understand. In fact, we might be accepting an ECMO paper in radiographics, so it's all good.
Yeah, actually, well,
I
I don't know if you guys want to see this again. At the beginning of COVID, I actually presented this here, and it took me a while to figure this out, but veno is like basically they remove deoxygenated blood, put it through the machine, and then they can put it back in, for example, through the SVC. So you want to make sure these 2 catheters are not too close together so that you're not like sucking out the oxygenated blood that just got put back in. And then veno arterial, like I was saying, is more for cardiac disease. And then they remove the blood, maybe from the SVC, and then put the oxygenated blood back into the aorta here, because the heart can't even pump it back out. So here on veno, you're assuming like once it goes in, oh, the heart's going to pump it back out. Veno arterial kind of takes out the heart needing to do that work. And then basically a lot of this you're getting, even though the blood you're putting back in is like 100%, by the time all this blood mixes, the blood that goes to your brain is about 50% oxygenated. So it's just enough to kind of, keep you going. Okay, this I just pulled up. Actually, it's a companion case to Anu's case. I just thought it was kind of cute. This patient has a cluster sign, hepatic abscesses, biliary dilation, but then they had this kind of stuff here, this kind of looked like soft tissue. I'll show you the coronal. And I was really concerned that there was like an intraductal cholangio and all of this stuff here. And then they also had basically a stuff at the hilum. But anyway, they ended up going for ERCP, and all of this was just pus and debris. They did like extensive biopsies and brushings, and all of this was cholangitis with like pus, debris, and then that was what was causing these like little micro abscesses in the liver, one of which has a drain in it. So
What was the cause of all of this? Like, was there?
no, I was like, is this RPC, like recurrent pyogenic cholangitis? No, I mean, and actually, I don't know, they did have a stitcher.
Diabetes.
What'd you say?
I said sometimes it's just poorly controlled diabetes and fuck.
Yeah, I don't know. But anyway,
Or some weirdo cholangiopathy. I don't know. They're like some drug related or something else.
yeah.
Okay, cool. My turn?
Yep.
Okay, let me. Are we good? Can you see my screen?
Yes.
Yes.
Yeah.
Okay, great. So this is a cirrhotic patient, and I've never seen this pump thing before. So then there's this catheter, and then like it went into the bladder, and there's a second tubing into the peritoneum.
Is this some sort of peritoneal urinary shunt?
Yeah, it's called an alpha pump. And I'm gonna.
I've never seen that. That is so weird.
Here, this thing. Yeah, I had to look it up.
I gotta tell my IR folks about this. They might start wanting to put it.
Yeah, so it's for refractory ascites, and this pump, the peritoneal catheter, just sucks it out, goes into the pump, and then that pump then pumps it into the bladder, and then the patient just urinates it out. Cool, huh?
That is so cool. This is a solution to our paracentesis backup service problem.
That was really cool. Okay,
although they must have to go to the bathroom a lot then.
Honestly.
Yeah, yeah, very possible. Yeah, I don't know. So there's a lesion in the anterior bladder wall. Here's the axial. Here's, what do you guys think? This came to our gynecologist. Here's the T2.
Could be another leiomyoma.
Yeah, so this was resected and it came back to be a bladder leiomyoma. Just a cute companion case. Okay, now this other one. So that was that. We're at 10:50. Should I show? Hopefully I can access this other one easily. Maybe not. I don't know. Okay, I'll just stop there because I'm not able to go back and forth between the two screens easily.
Cool. I just want to show one more thing about my ECMO thing because a couple of people messaged me about it. I forgot to show the second slide in my thing, but basically when you're looking at ECMO catheters on x-rays, your venous catheter, if it's two different lumens, then the venous one should be terminating, I believe, in the IVC just below the right atrium, and the arterial catheter should terminate in the SVC, so that they're far enough apart so you're not sucking the oxygenated blood out the other side so that it can go into the right atrium and ventricle. And then when you have a dual lumen one, again, this one should be in the IVC, and then the oxygenated blood should be pushed into the SVC. Okay. Cool. Nelly, you want to try again? Are you done?
I could try again. I'm going to try something different. Just load it directly from a different source. See, this is this lesion up here. And then any thoughts as what this could this be? And then I can show you the MR images.
Are you showing that hypodense lesion that you're on right now?
Yeah, this little,
What's the attenuation of that?
it's negative Hounsfield unit.
So it's like a pseudo-lipoma of Glissen's capsule.
Yeah, it's just a cute case. So here's the
Yeah, that's good.
post-face imaging. So cute. So it's exactly right. Pseudolipoma of the Glisson capsule, and it's like an colonic epiploic fat that kind of locates posteriorly to the capsule. And they have that classic location and classic appearance. They're fat attenuation like this, and they're usually in this location, sneaks up behind the liver capsule.
Yeah, I always tell my residents it's because of the peritoneal cycle, which pushes stuff between the liver and the diaphragm. It goes in that direction, and that's why things get stuck between the liver and the diaphragm. And also that's why you get like peritoneal mets that get stuck up there, and then endometriosis deposits that go up there and then go through the diaphragm to the right lung base.